This is an AP oral med production, to be used as a teaching tool at the user's own consent.
White patches in the mouth could be due to trauma, thickening of the outer layer, infection such as Candida, skin disease such as lichen planus, pemphigus, pemphigoid, at-risk lesions, oral cancer. This 50-year-old female presents with a white ulcerated lesion on the ventral anterior tongue. She has a medical history of hypertension, diabetes, which indicates immune compromise. Does she have high-risk habits such as smoking and drinking alcohol? Is there exposure to HPV? Is their diet adequate? The clinical photograph shows an adult face with lower lip. The lip appears dry but healthy. The ventral surface of the tongue on the right anterior aspect shows striated white lesion area and also an ulcerated area. Impression: this is a high-risk site. This could be lichen planus or other vesiculo-bullous lesion, hyperplastic candidosis, dysplastic lesion or a squamous cell carcinoma. A biopsy for histopathology is mandatory. Lichen planus (OLP) is suggested to be an autoimmune disorder. It may present with lesions on the skin, the nails, the scalp and genital areas as well as in the mouth. In the mouth they may appear white lace-like, red, ulcerated or thickened white patches. In the mouth they may occur on the tongue, the cheeks, the gingiva as desquamative lesions and the palate. OLP occurs mainly in females in that 40 to 70 age group. It is a T-cell-mediated immune lesion. Some lesions may look similar to other vesiculo-bullous lesions. Diagnosis is by clinical history and picture followed by a biopsy. Management involves topical steroids to reduce the T-cell reaction and regular review as there is a 1% risk of change to cancer. This clinical photograph shows an ulcerated white-red lesion on the anterior ventral right tongue. A biopsy of this lesion indicated this to be a squamous cell carcinoma. So as you can see, these lesions can have a similar picture to the previous slide but in fact a more sinister lesion. This is a good point to introduce oral potentially malignant disorders (OPMD). A list of these conditions include 1. Leukoplakia, a predominantly white lesion which cannot be diagnosed as any other lesion. 2. Erythroplakia are predominantly red lesions which cannot be diagnosed as any other lesion. These have a higher risk of malignant change. 3. Proliferative verrucous leukoplakia (PVL) is diagnosed in retrospect. PVL involves multiple white lesions in the oral cavity which under histopathology may be hyperkeratosis. Dysplastic and/or OMSCC4. Oral lichen planus as discussed previously. 5. Oral submucous fibrosis common amongst people that use betel quid, especially on the Indian subcontinent. This habit leads to fibrosis of the connective tissue in the mucosa and clinically with a pale appearance due to the fibrous band which restricts mouth opening. 6. Palatal lesions in reverse smoking. 7. Lupus erythematosus. 8. Dyskeratosis congenita. Epidermolysis bullosa has been removed as an OPMD due to lack of evidence for malignant potential. Hyperplastic candidosis and an oral exophytic verrucous hyperplasia also have lack of evidence to consider these as OPMD. Dysplasia may be mild, moderate or severe, also called carcinoma in situ. 36% OD dysplastic lesions are said to change to malignant disease, but so can 16% of non-dysplastic lesions. 50% of biopsied leukoplakia may show dysplasia, but not all progress to carcinoma. Severe dysplasia has a higher risk of progression whereas mild does not. So this makes management of mild dysplasia a dilemma. Do you observe or do you excise? Oral lichenoid lesions are clinically the same as OLP but may be associated with medications, restorations or immune problems such as graft versus host disease. Oral submucous fibrosis was also discussed before, but clinically may cause burning, loss of pigmentation, leathery mucosa and sunken cheeks. See clinical photograph. OPMD lesions carry a risk for OMSCC, redness or the lesion being larger than 2 cm increases the risk. Under histopathology, loss of heterozygosity, analysis of DNA content ploidy may indicate risk. Other known risk factors include genetics. Smoking, alcohol consumption, diet, infections such as viral, fungal such as candidosis, sunlight for lip carcinoma. Also, as seen on the algorithm, level of dysplasia will affect risk.